Good morning. Welcome to the Wilson Center. I'm Sarah Barnes, and I'm the project director for the Maternal Health Initiative. And I'm so glad that today, on World Preeclampsia Day, the Maternal Health Initiative was able to partner with Population Council and its Endingeclampsia program to bring you this very important discussion on non-communicable diseases, preeclampsia risk factors, and long-term complications. Preeclampsia is a serious disease related to high blood pressure that can happen to any pregnant woman in the second half of their pregnancy or up to 6 weeks postpartum. Recent statistics show that hypertensive disorders of pregnancy, or HDPs, which this includes eclampsia and preeclampsia, complicate 8 to 10% of all pregnancies worldwide. HDPs are also a leading cause of maternal and infant death. Approximately 76,000 maternal deaths and 500,000 infant deaths every year are attributed to HDPs. Eclampsia is Greek for lightning, which I just learned from this World Preeclampsia Day one-pager. So it strikes quickly and can be devastating. Knowing the risk factors and signs of preeclampsia is essential to the lives and health of women and children. Luckily today, we have an incredible team of discussants to lead us in this conversation. Our moderator is Jill Keesbury. Jill is the Senior Director of Technical Strategy in the Health Programs Group at Management Sciences for Health. And our panelists today are Dr. Lucia Larson, Dr. Tabassum Feroz, Dr. Kathleen Hill, and Charlotte Warren. And starting us off today with her experience in Ethiopia with an eclampsia survivor is Amy Dempsey. Amy Dempsey is a knowledge translation and advocacy manager for maternal and newborn health at the Population Council. A special thank you to Amy and all of our panelists and moderator for helping us put together this event today. Thank you. Over to you.
So thank you all for coming, and thank you to those who are tuning in on the webcast. As you know, today is World Preeclampsia Day, and the Endingeclampsia Project is a co-sponsor, along with the Preeclampsia Foundation, Baby Center, the International Society for Studies of Hypertension and Pregnancy, and the Precise Project. World Preeclampsia Day is meant to bring together maternal health advocates and experts, all of you, to not only discuss the ways in which preeclampsia and eclampsia impact women and babies, but also to talk about the challenges that women and girls face when accessing antenatal care and early detection of risk factors like chronic hypertension, kidney disease, obesity, and diabetes, as well as the management and treatment of long-term chronic health complications associated with preeclampsia. The Endingeclampsia Project is conducting research in these areas in Bangladesh, Ethiopia, Kenya, Nigeria, and Pakistan. And in all of these countries, we've spoken to women who have had very little knowledge and awareness of complications in pregnancy until they themselves experienced one. As Sarah mentioned, I was recently in Ethiopia, and I met an eclampsia survivor. She's now 5 months postpartum and has a really healthy baby boy. But pregnancy was the first time she had ever stepped foot in a health facility. And throughout her pregnancy, she had experienced several of the symptoms that we know are associated with preeclampsia. She had constant headaches and blurry vision, but she went to 8 antenatal care visits, which we also all know is pretty uncommon for women in low and middle income countries. And at each visit, her providers measured her blood pressure, but none of them told her that it was high or why they were measuring it. She was told that what she was feeling was normal for a pregnant woman, and after one contact point with the health system, she was sent home with paracetamol to treat her headaches. And one evening in the 8th month of her pregnancy, she started having seizures and she collapsed in her home. The next morning, her husband was able to borrow a car and he drove her to their church, believing that holy water and prayer could save her. But when her condition didn't improve, he took her back to their local healthcare facility, and from there, providers referred her to a higher level hospital. She doesn't remember the time she spent in the hospital, but she knows now that she was given magnesium sulfate to stop the seizures, and she was also given an emergency cesarean section. She woke up 5 days later after her cesarean section to find out that she had delivered a healthy baby. Now, after leaving the hospital, she went back to the healthcare facility 2 times for postnatal care. And the first visit, she and her baby were both examined, but at the second visit, only her baby was examined. That second visit was 5 months ago, and she hasn't had any contact with the health system in Ethiopia since that time. She still experiences the same symptoms that she experienced when she was pregnant. She has really bad headaches and very blurry vision. And as I was sitting in her living room talking to her, she pointed to her ribcage and told me that she was still experiencing abdominal pain in that moment. So this is a woman who did exactly what she's supposed to do. She did exactly what we encourage pregnant women to do. She went early and often for antenatal care, and she talked to her providers about the symptoms that she was experiencing. And despite that, she was never told that what she was experiencing were symptoms of preeclampsia. It wasn't until I, via my translator, told her that what she had gone through wasn't normal and was in fact a life-threatening complication in pregnancy. Now, this woman's story may be anecdotal, but we've all seen in our work that what she went through is fairly common for women in low and middle-income countries, where challenges they encounter are quite different from the barriers that women in high-income countries deal with. And so today's conversation is going to address detection, management, and treatment in both contexts, and is specifically going to focus on the non-communicable diseases that increase women's risk for preeclampsia, as well as the NCDs that are possible long-term complications. And so with that, I will hand it over to Jill, and thank you so much.
It's very important that everyone knows who I am. Thanks for that, Amy. That's a really great reminder of why we're here today and why this discussion is so important. This is especially relevant because we're all hearing news, I'm sure, from our colleagues who are at the World Health Assembly right now, and hearing that there's more and more discussion about NCDs and their role in ensuring universal health coverage. And I don't know if folks have seen it, but yesterday, WHO released a new report on the health impacts and economic returns for investing in NCDs. And one of the 6 best buys that it identified was preventing and managing cardiovascular disease and diabetes. So we've got a really exciting panel here today that will help us explore how to address these conditions, especially in the context of pregnancy and the extended postpartum period. I think what's especially interesting about this panel today is how it balances the issues of high and low resource settings. So our panelists are here to help us understand what interventions are most effective across these contexts and how these high-impact practices can be applied differentially in different settings and different systems. So this is a relatively new set of issues for us in global health. And today's discussion is intended to help us understand better what's working, what we know, and very importantly, what we still don't know about how to address the intersection of NCDs and hypertensive disorders in pregnancies across the world. So we've got a really great panel, and I'd like to introduce our first panelist, who's Dr. Lucille Larson, the Director of Obstetric Medicine for the Women's Medicine Collaborative in Providence, Rhode Island, and an Associate Professor at Brown University. She is a practicing physician and has conducted extensive research on NCDs and pregnancy. So, Lucia, can you talk about specifically diabetes and obesity in the context of hypertensive disorders from your perspective as a clinician in the U.S.?
Sure. I think what I'll first do is actually explain to you what an obstetric internist is, or obstetric medicine physician. I am trained in internal medicine, but did extra fellowship work in taking care of medical problems in pregnancy. So I'm not an obstetrician, but when I see these patients, I come to them seeing pregnancy more as a stage of life, because I'm used to thinking about these patients for their health before they got pregnant and then after they got pregnant. So that's kind of my approach for this. Taking care of them during pregnancy is one of my passions, and so that's a very exciting time in life, but it's not the only piece of a woman's life. for us to take care of. In regards to preeclampsia, there are a number of risk factors for preeclampsia that many of you are probably aware of, including hypertension. Many of these risk factors or diseases that are risk factors are associated with increased inflammation in the body and with increased atherosclerosis, those sorts of diseases. In particular, obesity and diabetes is what I was going to talk about today. So we do know that obesity increases the risk for preeclampsia by at least twofold. Every 5 to 7 BMI units increased doubles that risk even more. So it's a significant increase. The other thing is that we all know that diabetes is associated with obesity. That's yet another risk factor for preeclampsia. We know that gestational diabetes, which is basically diabetes in pregnancy, that is unmasked during the pregnancy, a predisposition towards diabetes later in life actually, increases the risk for preeclampsia as well. Ideally, if we can get a hold of a woman prior to pregnancy and take care of any of the risk factors for diabetes and help her be a healthy weight and have a healthy lifestyle, then ideally we can help her enter a pregnancy at a lower risk for preeclampsia. We know that women who are obese going into pregnancy are more likely to have excessive gestational weight gain. Women who gain excessive weight during pregnancy are more likely to have postpartum weight retention. And then very often that means that they're going to go into their next pregnancy at a higher weight, and then the cycle goes on. This also affects the offspring for these pregnancies. We know that women who are obese and who have diabetes or gestational diabetes, that those babies are more likely to be macrosomic. Those macrosomic or large babies. These babies are metabolically less healthy. It's not like a LeBron James, big, healthy, strong kind of big that we're talking about. It's sort of metabolically less healthy. These are babies that are at increased risk for childhood obesity, that are at risk for diabetes in childhood, and increased cardiovascular risks as well later in life. And so there is this little bit of intergenerational cycle that can go on. Both obesity and high blood sugars going into pregnancies are independently associated with congenital anomalies as well. So that makes a difference for the health of the pregnancy and for the health of the offspring. We know that women who have gestational diabetes, that is elevated blood sugar diagnosed during pregnancy, that even at their postpartum visits, if they test normal with normal blood sugars, that they're at increased risk for the future development of diabetes over the next 5 to 10 years, somewhere in the range, depending on the population, of 50 to 70%. So it's really quite high. And ideally, we would know about these women before another pregnancy if they had an intervening diagnosis of diabetes, to take care of that before they got pregnant, so they went into the next pregnancy with healthier, lowering their risk factor for preeclampsia as well. So at our institution, I'll tell you just a little bit about a program that we have. We call it Healthy for You, Healthy for Two. It is focused on women of reproductive age. We take care of patients. Most women don't actually present pre-pregnancy for counseling. I wish we had more preconception counseling. I find that probably half of the women who come to us for preconception counseling a week later will call us with a positive pregnancy test and say, "Oh, surprise, I'm pregnant and I didn't even know it." But if we can get a hold of them for preconception counseling, then we can work with them with lifestyle modification to try and improve their weight and metabolic profiles for pregnancy. During pregnancy, we will meet with them and work with them with lifestyle modification to at least try and minimize gestational weight gain or have an appropriate gestational weight gain, not have excessive gestational weight gain. And then we see them in the postpartum period, and we'll follow them for as long as they will in terms of lifestyle modification to get them healthy for their next pregnancy. Often that's really our best way of getting a hold of women is during a pregnancy and then to set them up for a healthier pregnancy the next time around. We do a program where we have a group visit, actually. Women who've had gestational diabetes get a 2-hour glucose tolerance test at 6 to 12 weeks postpartum. So women will come in fasting, then they sit in the lab for 2 hours and then get a 2-hour blood sugar drawn on them. So we've decided to take that captive audience and we do a group visit with them. We will talk with them about breastfeeding to try and help women along who are needing a little extra help with breastfeeding at that time. We will talk with them about postpartum depression, and we will find that actually that group dynamic is really very important and very helpful to engage them, particularly women who may need a little extra help with that. We'll talk a little bit more about nutrition, although many of those women have pretty good background in nutrition as we've been working with them during pregnancy with gestational diabetes, do a little physical therapy for body health, and everyone seems to have back pain when they're nursing their babes. And so we work with that, and over that 2-hour period, I think we actually accomplish a lot to try and help bring them along. I think my time's up, but okay.
Well, great. Thanks, Lucy. That was really interesting. Now I'd like to turn to Dr. Tabassum Feroz, who practices internal medicine and obstetric medicine at Yale New Haven Health. Tabassum's work straddles both high and low income country contexts, and she's been a part of developing the development committee for the Canadian Guidelines for Hypertension and Pregnancy, and has published on managing hypertensive disorders in contexts as vastly different as Canada, Mozambique, and Pakistan. So Tabassum, can you talk about the risk factors and the issues associated with managing chronic kidney and cardiovascular diseases across all these different settings?
Thank you, Jill. I just first wanted to say I'm really excited to be here because this is a first-time event where an event has actually focused on long-term complications, and I hope that this will be the first of many discussions and dialogue on this topic. Before I start, I just wanted to very briefly mention that I've had the opportunity to practice obstetric medicine in Canada and the US, and I think the lessons learned there are translatable to low and middle income countries. In Canada, I worked with a very complex new immigrant population with a lot of unmet medical needs. So when they would present, they would often have really complex, complicated diseases within pregnancy and postpartum. We also often dealt with our Indigenous population who would be rural and remote and would fly in to see us. In the US, the challenges were a little different. Lucia and I actually worked together in Providence, and the main one that really stood out to me coming from the Canadian socialized healthcare system was related to the financial aspect. And I think that's a real challenge also in low and middle income countries. So I'm focusing on cardiovascular disease and chronic kidney disease and how they're related to preeclampsia. I'd like to begin by just setting the stage, and many of you have probably heard this, that pregnancy is a stress test. So when a woman undergoes preeclampsia, unfortunately, she has not passed that stress test, and we don't need to see that as a negative necessarily. This we should turn into a positive because we can now use that pregnancy as a window of opportunity to identify our high-risk women and screen them and find a way to transition them into long-term care that extends much more than just the pregnancy and beyond their reproductive years, as Lucia alluded to. When a woman is generally young and healthy as she is when she is pregnant, the only time she really seeks care is during pregnancy. So it's that perfect opportunity to connect her to the health system and transition her from pregnancy and reproduction into lifelong care. Lucia already alluded to this. Preeclampsia is an inflammatory syndrome, and it's no surprise that preeclampsia shares a common pathophysiology with cardiovascular disease and chronic kidney disease. I'd really like to highlight that it's so important for us to follow these women following preeclampsia because they remain at risk for premature and early cardiovascular disease. We don't know the data necessarily for renal disease, how early they develop end-stage renal disease, but we know that they get chronic kidney disease even as early as right after the index pregnancy. There are two camps of thought, one that says that perhaps these women were already predisposed to preeclampsia, and another camp that says, well, it's preeclampsia that then leads them to go on to develop these chronic diseases. But we're probably somewhere in the middle, that these women were probably predisposed and preeclampsia further exacerbates the inflammatory condition. There's been a model proposed where they've said that women have subclinical disease, and it goes back again to the risk factors that Lucia alluded to, that perhaps they weren't quite, they didn't have abnormal blood pressure readings, but they were not quite normal either, so they were just on the borderline. Their body mass indices were also just borderline and other metabolic parameters. Similar to this in chronic kidney disease, obesity has come out to be an important linkage between women who develop preeclampsia and go on to develop chronic kidney disease, and perhaps something we didn't study as much. And perhaps they even had pre-existing proteinuria, or protein in their urine, that then predisposed them to preeclampsia, and then they go on to develop chronic kidney disease. So with this in mind, when we're discussing long-term follow-up, we need to start back at the beginning and go back to good preconception care and that identification of women who might need extra care or who might be considered high risk. So what then are the risks when a woman has preeclampsia related to cardiovascular disease and chronic kidney disease? And here we need to think about risk factors related to the pregnancy, such as what type of hypertensive disorder did she have? Was it gestational hypertension, preeclampsia, or eclampsia? When did it occur? And did it recur? So we know that for cardiovascular disease, preeclampsia has a higher risk of future heart disease. So this is stroke, high blood pressure, ischemic heart disease, than gestational hypertension. If a woman develops preeclampsia before 37 weeks, some studies have shown that they will have a 7-fold increase in their risk of heart disease, whereas if they haven't, it's about a 2 to 3-fold increase. And if a woman has recurrent disease, preeclampsia, her risk of future cardiovascular disease and even death related to cardiovascular disease is much higher than a woman who had preeclampsia only once. But we need to also bring in the child health component here because the perinatal characteristics also influences how a woman develops her future risk of cardiovascular disease. So what I mean by this is women who've had a placental abruption or infarction, or if she's had a growth-restricted baby or a stillbirth, is at higher risk of getting cardiovascular disease than a woman who has not. And how quickly does she get this cardiovascular disease? It can be as early as 10 to 12 years after her index pregnancy. So we're looking at women who might develop it as early as their 30s or 40s. So I talked about how one camp of thought thinks that maybe these women were predisposed, but there is some data showing that maybe the other camp that says that preeclampsia increases the risk is very much true as well. There was a study done in Canada that showed that women who had preeclampsia and then went on to develop cardiovascular risk, if they underwent coronary intervention, so like getting a stent in, regardless of the fact that they got good care and the stent, they ended up dying more prematurely than women who did not have preeclampsia. So perhaps there's something to be said about just preeclampsia alone. So how do we then screen these women and manage them? So we don't quite know when exactly we should be screening these women. Typically, we screen them with known risk factors like blood pressure, cholesterol, weight, but we don't have the timing exactly. And I think this needs to be dependent on the health system. but also dependent on the barriers that women face. Both in low and high income countries, women express barriers such as time, cost, a lack of knowledge about what has actually happened to them in pregnancy, and the physiologic and psychological recovery after pregnancy. When I was working in Vancouver, Canada, I conducted a small study with South Asian women because that was my main population. And I think that really showed that we have to keep the sociocultural context in mind. Some South Asian women mentioned that after having a baby, their responsibilities increased, yet at the same time, their supports were different. They had in-laws to help, sister-in-laws, mother-in-laws. And they also mentioned that perhaps involving the larger South Asian community at large would be helpful, and when asked how, it was mainly around getting culturally specific food recipes or having a helpline where they could address stress and anxiety. A great facilitator that women have mentioned across cultures is that understanding their health and improving their health for the sake of their child would motivate them to pursue a heart-healthy lifestyle. And I think this would signify to us that we need to marry maternal and child health and how we deliver our care. So what do we do now? So the components of our postpartum care really need to be in place. So this would be hypertension screening for hypertension and proteinuria. And going back to chronic kidney disease, similar to cardiovascular disease, women are at higher risk. This can be as high as 9-fold for women developing chronic kidney disease and even end-stage renal disease requiring dialysis. So we need to also be screening for proteinuria, again, the timing of which remains a bit uncertain. We also need to think about how many postpartum visits we need to be offering women, and maybe just 4 visits isn't enough. And we need to tailor it to the individual woman and the complexity of our disease, keeping in mind the health system challenges. We also probably need to think about innovative ways of delivering postpartum care. Lucia already alluded to this. Group postpartum care might be a strategy, especially because all we know right now in improving cardiovascular disease, and we don't know as much about what to do with chronic kidney disease other than follow women, is delivering a heart-healthy lifestyle. So what does that mean across cultures and different contexts, and how do we engage women? And perhaps one little strategy that we can think about is also breastfeeding, because breastfeeding has been shown to improve metabolic parameters and have a positive effect on hypertension, yet we do want to leave that up to the individual woman and her current individualized situation. Finally, I'd like to say in terms of addressing this, that transitioning the woman to long-term care means we need to strengthen primary care services and integrate the NCD agenda with the maternal health agenda. Some of these are very lofty, but I think, unfortunately, without these in place, we won't be able to give women the life course approach and the care that they need.
Great. Thanks, Tabassum. That was really good. Now let's turn to thinking about low resource settings. And we're lucky to have Kathleen Hill, who's a clinician and the maternal health team lead for USAID's flagship maternal and child survival program. She's worked all across the world in sub-Saharan Africa, Latin America, and the Caribbean, and Eastern Europe, all in ensuring that women have access to quality, respectful care. And she's the co-chair of WHO's really important new Quality, Equity, and Dignity Network. So Kathleen, from all of your work in low resource settings, what are the major issues that you're seeing associated with NCDs and hypertensive disorders in pregnancy?
Thanks very much. And I'd like to just start by thanking Endingeclampsia Project for inviting us to be a part of this panel. We're really delighted. As Jill mentioned, I'm very fortunate to lead the maternal health team on USAID's Global Maternal Child Survival Program, and we've really had the pleasure of collaborating closely with Endingeclampsia at global level as well as in multiple countries. In fact, Charlotte and I a year ago were off in rural primary health centers in Kogi State, Nigeria, looking at all kinds of issues related to the topic we're discussing. So MCSP, the Maternal Child Survival Program, works across multiple countries. So I'll be talking a little bit about my perspective, and I'm sure Charlotte will reinforce this, about some of the patterns and relevance for the topics that we're discussing today. And I am so glad to see this topic because it's something that I think many of us who are working in maternal health have been, desperate to see more of. So I'll just start by kind of at the global level saying that WHO in 2014 did the latest, multi-country analysis of causes of maternal deaths. And at that time, they estimated that 14% of maternal deaths are due to hypertensive disorders and that 28% of deaths are due to indirect causes, which would include, hypertension, HIV, malaria, anemia. I think what's interesting is that the 20% due to indirect causes now matches the percent of deaths due to the leading direct cause of maternal mortality, which is PPH. So we've really, in a sense, I think, been, very much neglecting the part of the maternal morbidity and mortality picture that relates to indirect causes. And I think, from my perspective, that in global health, I think it's less true in high-resource settings, as we're hearing, but I think in global health, there's been, perhaps understandably, a tendency to have focused a lot on direct causes, PPH, eclampsia, infection, obstructed labor, all the focus on emergency, obstetric newborn care, which, had its rationale, but the downside is, I think, that we've really neglected the continuum. And in a sense, I think preeclampsia and hypertensive disorders of pregnancy are particularly intriguing because you really can't easily divide them into indirect and direct. It's an artificial division, and I think it perhaps challenges all of us to, especially in global health, I think this has been less true in high-resource settings, but to sort of reconceptualize a little bit how we're thinking about maternal health. And there was an interesting editorial in The Lancet on this topic about, is it time to move beyond direct and indirect causes? We know that about 10% of pregnancies in low and middle income countries are complicated by hypertension, but actually the data on this is very weak. We have lots more data from high resource settings, but because so many women enter late into antenatal care, very often we don't know whether a woman is coming in with gestational hypertension or established chronic hypertension, or maybe preeclampsia if she has other stigma. So even the classification and understanding of the form of hypertensive disorder that a woman has at a particular moment is often hard to tell, particularly in women that enroll late. We also know that in many settings where we're working, there's just generally limited awareness of non-communicable diseases. I think it's changing, but as compared with high-resource settings where I think there's now, it's taken us years and years, but there is a general appreciation. I think that high blood pressure is sort of a silent killer and that, you do need to think about high blood pressure. I think we're just beginning to really get there, and we know that primary care platforms are really, for the most part, rudimentary to non-existent in many low-resource settings. And I know, Jill, you mentioned the World Health Assembly and universal health coverage in primary care, and this is really heartwarming to see because I think, as we've all been saying, this is not, this is a life cycle continuum of care, and this isn't going to be, we can't look at this as just episodic based on a pregnancy episode. It's about a life cycle. So I'd like to talk a little bit now about some more specifics related to low-resource settings and health systems and the continuums of care, both across the life cycle, from preconception to pregnancy to intrapartum to early postpartum to extended postpartum. And I think we heard a lot from Lucia and Tabasum about the importance of this period. And then also talk a little bit about some of the systems issues. So preconception care is really, I would say, based on our experience and, in MCSP, is not certainly something that is frequently talked about. And even in certainly high-resource settings, we struggle, but I'd like to give Mark Hathaway some credit here. Mark and I both work at a large consortium of community health centers here in DC. And thanks to Mark's advocacy, we now have a fifth vital sign for every single woman that comes into the community health center. She is asked, do you want to be pregnant in the next year? And when the clinician goes in to see her, the nurse practitioner or the physician or the physician's assistant, you have that right in front of you. So you're either addressing birth control, contraceptive, or you're addressing her preconception needs. And this has been hugely helpful for all of us, and I think has really pushed us to take preconception care much, much more seriously. And for the woman who does have risk factors, who is coming in saying she wants to be pregnant in the first year, that visit goes very differently because of that, quote, fifth vital sign. So thank you, Mark. For most women in low and middle income settings, pregnancy and childbirth may be the only touch points they have with the formal health system. And so this is just an incredibly important opportunity to capitalize on. And yet we know that even when it comes to antenatal care, where we have probably the best uptake in terms of women's utilization of services, we still, in many low-resource settings, are, as I think Amy was alluding to, are most women getting maybe one ANC visit, many fewer women getting even the previously recommended 4 ANC visits, and certainly the 8 ANC visits that Amy described is very rare, at least in the lowest resource settings. And so as many of us know, WHO changed their recommendations for ANC and increased the number of visits to 8 from 4, primarily because of the increased risk of preeclampsia and perinatal adverse effects and perinatal mortality due to undiagnosed and undetected and unmanaged preeclampsia. And yet, for many countries, this is still far beyond their reach. I mean, I was recently in Nigeria, where Nigeria's, we're working with Endingeclampsia and with MCSP and other partners to update the national ANC guidelines. They have made a decision they are not going to go to the 8 visit because they can barely do the 4 visit. So these are the realities of sort of what we're having to juggle. I think when it comes to postpartum follow-up, and I think we heard a lot of really helpful points about the importance of this period for following women and screening and detecting, we know that this is still really, even less uptake than for ANC, where we have at least a little bit of uptake. And of course, this varies by country, but I would say, we've been trying for 10 years to talk about postpartum care for women, and I would say that in many countries, even one postpartum visit is not happening. So I think, I have a colleague here from Rwanda, so I'm thinking as I'm talking, I'd love to hear his thoughts. Rwanda, in some ways, I think is an example for many of us, but certainly in many of the settings where we're working, even one postpartum visit is not happening. And we, working with other partners, updated WHO's Managing Complications in Pregnancy and Childbirth in 2017. We updated a second edition, and we actually added an entire section on postpartum care, because for the woman who is there during, a facility delivery, because it may be the only point at which we have to reach her. And we added a whole section on, health promotion and behavioral counseling, but also very targeted, tailored follow-up and counseling for women who have preeclampsia and other risk factors that we know predispose them both to future life disease as well as future risks in pregnancy, so that they know that they need to come back early and also to offer them prevention. We know that in some studies, we've been hearing about the increased risk of cardiovascular disease, that it's 2 to 3-fold higher. And I think for some people, they might think, well, cardiovascular disease, it's a future long-term problem. There was a study done in the US in 2014 that showed that 30% of women who were diagnosed with preeclampsia at term had high blood pressure by 2 years after the incident pregnancy. So this is not a remote risk. This is here today, and we have to, I think Tabassum really, really put it well, what we're struggling with, which is we don't really know how and when we should be screening women, but we know we need to be doing better. I think that my fellow panelists mentioned ANC group care as a promising strategy. I know that it's been widely used in low-resource settings, including, we heard from our colleagues, certainly in the clinics where I work, it's pretty much the standard of care. And I think we now have some great evidence, actually the first study ever by Pop Council coming out of northern Nigeria, showing increased ANC uptake, increased facility delivery, increased postpartum care uptake, and JPIGO now is leading a large study in Nigeria and Kenya that is also showing very similar findings. So I think service delivery models like Group ANC are potentially very promising for getting women not only into antenatal care, and increased uptake of facility delivery, but also, very importantly, engaging them in this ongoing postpartum and extended period, which we know is so vital, particularly for women with risk factors. I'd like to just end by saying a few words about the health systems issues in low-resource settings, and I've worked as a clinician in both settings. I've, spent 3 or 4 years working in Niger in a district hospital and regional hospital, and I've, worked in the U.S. and continue to work in the U.S. The health systems issues are so profoundly challenging, and so I think, we can't, and I know we'll be talking about this and we'll be talking about it more, but the issues of not having basic commodities, not having a blood pressure cuff that works, not having a urine dipstick, not having a glucometer, not having mag sulfate. We did a study across MCSP where we looked across 8 countries where we looked at hundreds of maternities, and over half of them didn't even have mag sulfate. So, we're just talking about a level of system fragility that is, I would say, really an emergency that we all have to step up and say, this is absolutely unacceptable. And of course, that translates into their ongoing care. And then issues related to provider skills. And also the global evidence, I would say, really trails behind high-resource settings. Doing a lot of work, as many of us do with WHO, we know that the global evidence is very slow to shift often. And this is what countries are using. When we updated the MCPC, Managing Pregnancies and Complications in Childbirth, it had been 15 years since it had been updated, and systolic blood pressure was not even part of routine detection and screening for preeclampsia. Can you imagine? And then I'd like to just also say briefly data. We don't even have standardized high-quality clinical patient care records in many settings. We don't have registers that track basic data. We can't follow even maternal health cause of death at the subnational level in 50% of 24 countries that we surveyed. So, we also are data poor. We're sort of working in the blind, and I'm not saying that high-resource settings have all the solutions. We don't. They're huge issues, as we all know in the U.S., but we do have a lot more data, and we're missing even the basic data often in the settings where we're working. So I just want to end by saying that, as Jill mentioned, MCSP and other partners are very involved with the WHO Quality, Equity, Dignity Multi-Country Network. And I think this is a promising network. It's very systems focused. It's very focused on clinical evidence-based practices as well as experience of care. And I think that it really holds promise because I think that hypertensive disorders of pregnancy, there's never going to be a simple magic bullet or intervention. It's never going to be about just mag sulfate. It's about clinical decision-making and timing and delivery. And that ultimately becomes a quality issue. And I think that this multi-country network, which is now getting off the ground in many countries and really taking hold with a lot of government leadership, is a very promising platform for all of us. Thank you.
Thanks, Kathleen. And I think you outlined the issues really well for Charlotte, who will talk about the global evidence base and her work in building that. Charlotte Warren has extensive experience across the world, across the UK and Africa, in improving reproductive, maternal, and newborn health. She lived and worked in Africa for 17 years and conducted really groundbreaking research on disrespect and abuse during childbirth in Kenya. Charlotte's currently the director of USAID's Endingeclampsia Project, which brought us all here today, and is with the Population Council. So Charlotte, can you talk about some of the work that you've done and been involved in building the global evidence base?
Thank you, Jill, and thank you all for coming on this very auspicious day, which is my mother's birthday primarily, but also that we have, all come together to really not celebrate preeclampsia, but celebrate the fact that we're shining the light on such a critical issue that affects so many women around the world. I'll talk about 3 things to just kind of reinforce the data that we really need to kind of get our teeth into, and then describe some of our work through the Endingeclampsia Project, and then look at some future research gaps that around hypertensive disorders in pregnancy and NCDs. So as has been said, that we know that hypertensive disorders in pregnancy are responsible for over 76,000 maternal deaths globally, killing a woman every 11 minutes. In low-income countries, a woman has approximately 300 times higher risk of dying of preeclampsia than women and eclampsia than a woman in a high-income country. Preeclampsia is a major underlying cause of late fetal and early neonatal deaths, 500,000 fetuses and newborns, amounting to 1,600 lives lost every day. And for every woman who dies, another 20 suffer life-altering morbidity, as we've heard from others today. We know that hypertensive disorders in pregnancy complicate 8 to 10% of pregnancies worldwide. We're still not quite sure, but we're likely, although not clear, we're potentially seeing an upward trend in incidence, likely related to increased maternal weight and sedentary lifestyle. And while preeclampsia causes greatest risk to women and babies, it's important to review all the hypertensive disorders in pregnancy in women at increased risk of morbidity and mortality. We know that preeclampsia and eclampsia increases risks of kidney failure and heart disease and stroke in later life, or not so later life. And babies born to mothers with preeclampsia may be preterm, low birth weight, and small for gestational age, all factors that carry an increased risk of kidney disease, metabolic disorders, and high blood pressure for the child later in life. Pregnant women in low and middle income countries are not consistently screened for gestational diabetes, even though those regions account for 85% of the global deliveries and 88% of GDM cases. And this the GDM is on the rise, affecting 1 in 7 births globally, and hyperglycemia is one of the most common medical conditions that women may encounter during pregnancy. So, the Endingeclampsia Project is a 5-year cooperative agreement award by USAID to Population Council in partnership with Ministries of Health and local obstetrics and midwifery societies. And we seek to expand access to quality underutilized interventions and commodities for the prevention, early detection and treatment of preeclampsia and eclampsia. When I first started this project, although I've worked in maternal health for many years, and yes, preeclampsia was one of the major killers, as we have discussed, I did not know to what extent and how deep we were going to dig into all these interconnected issues that on the first when you first think, oh, preeclampsia, oh, make sure everybody has access to magnesium sulfate. What about antihypertensives? What about the blood pressure cuffs? What about all these other links to NCDs? And it really is, the deeper we dig, the more we find and the more we don't know. So our key focus on this project is to really act as a catalyst to shine the light on preeclampsia and all the hypertensive disorders in pregnancy. We need to raise awareness on this life-threatening condition and these potential health consequences. And this is one of the reasons why we're holding this today. And we're thankful and appreciate our colleagues who are also partner organizations who have helped launch World Preeclampsia Day for the first time last year, and then today, and then hopefully going forward, we'll be increasing our knowledge on how to address this issue more closely. So Endingeclampsia has 3 main objectives. We're looking at expanding known interventions that have worked, conducting implementation research, and then to really push forward some high-impact practices that we've identified for other countries to pick up and take forward, looking at a minimum package of care that could be done at any level of the health system, and then to increase just globally information around or awareness around preeclampsia and strengthen global networks for knowledge translation at all levels. So expanding the use of proven high-impact practice is critical to accelerating a global reduction in maternal and perinatal morbidity and mortality. And the need is especially acute in low-income countries such as sub-Saharan Africa and South Asia, where 65 to 85% of women of populations are rural with limited access to life-saving healthcare. And we should not, of course, forget the increasing migration to urban areas where family and community support systems may not exist, and other social, cultural, economic challenges prevent access to timely care. For the Endingeclampsia Project, we're conducting research in 5 countries, that's Bangladesh, Nigeria, Pakistan, Ethiopia, and Kenya. The 2 of the countries where we first started have been our main focus are Nigeria and Bangladesh, where we built on work that we'd done previously under the MacArthur Foundation support, where we first introduced magnesium sulfate in northern Kenya and saw dramatic results. And we saw a 40% reduction in maternal mortality in some of the tertiary facilities just by introducing magnesium sulfate in some of those facilities. We know that in Nigeria, that 23% of direct causes of maternal mortality in tertiary facilities are due to hypertensive disorders in Kenya, which has overtaken the PPH at that level. And various factors such as the lack of capacity of healthcare providers to detect and monitor and embark on early referral of cases of preeclampsia at lower levels have been implicated as reasons for most of these avoidable deaths. We did landscape analysis in 3 countries, which looked at health facilities' readiness and healthcare providers' knowledge and skills to detect and manage HDPs, and these revealed huge gaps in the knowledge of lower-level healthcare providers as well as women. As we heard from Amy earlier, that the woman, even though she was accessing care, she didn't really know what she should have been receiving and the danger signs she should have been looking out for. We've included task shifting the use of magnesium sulfate to the lower levels at primary healthcare, where they give the loading dose and then refer to higher levels. We've also included the use of antihypertensives to women with severe hypertension at the primary healthcare level, and we've seen an increase in knowledge on when to introduce those antihypertensives from 14 to 86% among primary healthcare lower level providers in intervention sites, compared to only a 11 to 14 increase in comparison sites. We've been talking about women's groups. We've also looking at the using women's groups in southeastern Nigeria, and so that they know, so they can share with their colleagues, why they need to go for antenatal care, what they need to ask for, what the measurements are for. And we've seen women access antenatal care for the first time ever, even though they've had a number of pregnancies, are now accessing antenatal care because of the group kind of awareness around these issues. In Pakistan, we're strengthening the community midwives' skills. This is a cadre that was introduced by the Pakistan government in 2006 to try and increase access to skilled birth attendants. But although they're supposed to know how to manage preeclampsia and give magnesium sulfate, they'd never really done it, so we've been improving their skills there. But we also discovered that the doctors in the hospitals were also not using magnesium sulfate. So we've now trained all levels of that system in a particular district in Sindh province. So we've now seen an increase in the referral rate. We've seen more women delivering with the community midwives, as well as receiving the injection that saved my baby's life, as some women have said. In Ethiopia and Kenya, we've just done some more qualitative assessment, looking at a bottleneck analysis to understand the barriers women have in accessing care. And while the results have been disseminated at country level and will be available soon, there's not many surprises in the findings. The stock out of commodities, health providers' fear of using magnesium sulfate. However, the more detailed nuances will help policymakers and programmers understand where they should focus their efforts in low-resource settings. In many countries, including Nigeria and Bangladesh, nothing much is known about the kind of care women with hypertensive disorders have postnatally. We've been discussing this briefly here. There are no locally available guidelines that direct providers or care for women with hypertensive disorders of pregnancy, especially during the extended postnatal period. I don't even think women have their blood pressure checked at 6 weeks when they turn up with their baby to be immunized. And there are standard international guidelines, but even the WHO guidelines for preeclampsia prevention and management stop short of the postnatal period, the extended period. So we wanted to follow a cohort of women with preeclampsia to see what kind of care they and their babies receive, if any, and in reference and to NCDs. So in Nigeria and Bangladesh, we are working in a number of tertiary facilities. We're recruiting women or enrolling women at birth if they've had any kind of hypertensive disorder, and following them prospectively for 1 year to see. We want to quantify the magnitude of the gap in terms of quality of care, both for the mother and baby, and see the quality of care they receive, their outcomes, and identify any patterns of any morbidities specifically related to NCDs. We're midway through that study, and we hope to finish it in Nigeria by this time next year. One of the challenges in Bangladesh is that we've recruited, we're working in Dhaka Medical College, we've recruited over 100 women, or enrolled over 100 women, but when we try to contact them to come back for their checkup, they say, no, I feel fine, I don't need to come. Not realizing that actually we may need to just see. So we're now working out how we can, because all women with preeclampsia seem to come to that one major facility in Dhaka. So we're now looking at how we can go and meet with clusters of women at another facility that's nearer for them, so they don't have to travel so far. But yes, even where you may feel fine and your blood pressure is high, and that's the thing that many women don't realize. So finally, in addition to the research, we're looking at how we can, as I said earlier, shine the spotlight on hypertensive disorders in pregnancy and the risk factors associated with NCDs. We really do need to raise awareness at all levels, from individuals to policymakers, on how to detect and manage. I continue to be shocked at the lack of information women have, not only in lower and middle income countries, but people in the UK, here. Oh, well, I phoned my doctor and I said I had a headache, and they said take a shower, and the next minute her husband finds her collapsed on the ground suffering from a seizure. And elsewhere, well, I had this headache, but it could be malaria, so I didn't seek any care. In fact, there was a study done by in Ethiopia that was published a couple of years ago, where women had symptoms up to 15 days before seeking care, and the average was 5 days. Headache, well, it's malaria. Oh, well, it's normal for pregnancy. Oh, well, I've got this, I've got that. And especially around in other countries where women don't have agency to seek care themselves, the mother-in-law say, well, I had 10 babies, you don't need to go to hospital. And then again, they're seeking care very late. We know that task shifting some of the activities to lower level health providers to detect preeclampsia and to administer that loading dose and severe preeclampsia, it does work. And this is happening in many countries, and with good supervision, it does work. But because preeclampsia is reasonably rare, then you have to make sure that those skills that are imparted to lower level providers are kept going. If they don't give that first dose of magnesium sulfate within a short period of time of receiving training, then the likelihood of them doing it is less. It is a horrible thing to give. I mean, it's a big injection into the muscle on each side of the buttock, and then you have to give repeat ones. And so it's not a nice thing to give, and it's not a nice thing to receive. And so there's that kind of like, well, and maybe. So we need to overcome that challenge to make sure that women get access to the treatment as well as the follow-up. And we do know that when women are empowered and have agency on when to seek care and why and what they can demand, we see changes in health-seeking behavior and also when providers are empowered to use their skills and expertise, we can see changes as well. Regarding, we've seen that the magnesium sulfate can save lives. We've seen where it is available that it does save women, but we've yet to see the same impact on fetal and newborn survival. So how can we make sure that the very premature babies survive in low-income countries, as we see in high-income countries? We know that babies can survive from as early as 24, 25 weeks pregnancy. And what are those long-term consequences for those very preterm babies? Early detection and well-managed care will improve survival. Good preconception and early and continued antenatal care into the extended postpartum period can be provided relatively inexpensively and at lower levels of the health system. The challenge always is the implementation and quality care. How do we make sure lessons learned are not lost? How do we keep this issue of high hypertensive disorders from pregnancy and NCDs at the top of the agenda to support women to have healthy lives? Thanks.
Great. Thank you, Charlotte. What a wealth of information that you're gathering. That will be really helpful for all of us as we begin to address these more systematically. So We've been talking so far really about the services and focusing on the services themselves, but we heard from Amy earlier how important women's knowledge and the information given to them is in ensuring that women seek care and that it's adhered to. And we know that these barriers extend across the continuum that we've been talking about, from pre-pregnancy, preconception, to the extended postpartum period and beyond. So let's talk a little bit about the individual and community level barriers that women face in receiving adequate care. So Lucia, can you talk about what you're seeing in your practice and how you've been able to effectively overcome those barriers?
Effectively overcome. Well, we're trying. In regards to obesity and diabetes, pregnancy or not, we live in an obesogenic environment here in the U.S., certainly in Providence and other parts of the country as well. And along with that goes risk factors for diabetes, sedentary lifestyle. So the pregnant woman and the preconception woman and the postpartum woman is not immune to that. What I would say is that during pregnancy, I do think there is some permission for women to be able to attend to their needs more, recognition by family members and friends that they are going to need to eat healthy, take care of themselves. And so I do think that there is a time during pregnancy when women can be more successful. That said, as you know, women often have other young children to take care of. They're working. Some women are working 2 or even 3 jobs to take care of the financial needs of their home. And all those things add up and make it so much harder to do lifestyle changes. I think that when a woman has support of her husband or partner or other family members, that can be very helpful. Once a woman delivers and is in the postpartum period, she gets even busier than what she was. And I do think some of that social support actually goes away. And so it is harder for women during that time frame. And I suspect that that is a common theme in even low and middle income areas. From a provider point of view, it's actually hard to set up a sustainable program. Insurance reimbursements are not that great. Maybe it's getting better, but often into the postpartum period, women have less insurance. They have high deductibles. Hard to get food that's maybe as healthy for many women. There are some cultural dietary things that can become an issue that are less healthy. So having dietitians who are sensitive to cultural needs can be helpful. And then from a provider point of view, I do think many providers actually don't know this information. They may know this information intellectually, but they don't know it in such a way that it actually gets extended into patient care so that they're actually able to spend time for patients. They don't have time to spend with patients, and they're not getting reimbursed to spend the time with patients. So both sides, I think those are barriers.
Great. Thanks. Kathleen, I'm sure those are there are similar barriers in low resource settings, but there are also other community and individual level factors that are unique to those settings. Can you talk a little bit about the similarities and differences and how your programs have overcome those?
Sure. So I think, I think what Lucia's talking about rings very true. And I think Tabassum's point about the importance of the context, there was a really interesting study done looking at care seeking for both neonatal and maternal complications that was done by the Traction Project funded through USAID that really demonstrated for me the importance of context and not assuming that we necessarily know what the specific barriers are in a specific context. And I think that we need much more, informed formative research. But if I had to generalize, I would say what I think we all will resonate probably with most of us, which is it's really a combination of lack of awareness, lack of access, for financial reasons, for geographic reasons. I think the issue of the care that women receive in terms of how they're treated is probably hugely important. And we've done a lot of work around respectful maternity care. My guess is that if we can really dig in particular about how women with complications are treated, and this is where I think for providers who are working in very low resource settings, it's pretty challenging, and I think there's sort of a tendency to particularly sort of blame, why did you wait until now to come? I think the Gudu study that Charlotte mentioned was really eye-opening, which was looking at a regional hospital in Ethiopia and looking at just the sequence, the cascade of barriers with an average of 5.5 days to access, get diagnosed, and receive care for severe preeclampsia. And those were the lucky women, as you can imagine. I mean, can you imagine? And I think many of the studies show that there's often care seeking from multiple places. We assume, she just needs to get to the care. But actually, and I think the Lancet Maternal Health Series really looked into this, which is, how do we make sure that women can get to the right care? I think speaking of some of the cultural factors, and I know Tabassum commented on Southeast Asia, I've lived and worked a lot in West Africa, including the Sahel, Muslim West Africa, where women are actually, for 40 days, a month and a half, are sequestered, stay at home, and it's probably true in a lot of Muslim cultures. And so that also becomes, they don't leave the house for 40 days. So I think that it's not true in all countries, but in countries where that is the cultural norm, I think that's also a challenge. I think we need lots more sort of informed understanding of what the real barriers are and sort of the cascade of decisions and access that affect women's use of services. I think we generalize a lot, but we need much more contextual information.
Great. Thank you. Our discussion so far has touched on health systems issues consistently across all the different contexts. And since I'm from management sciences for health, which really focuses on health system strengthening for a variety of health outcomes, I'd like to really drill down on some of the issues that are the systems issues that affect the way women receive care. And what are the challenges that are faced within the system for most efficiently detecting and managing hypertensive disorders in pregnancy? So, Charlotte, from your research, what are the most pressing systems issues that need to be considered?
Thanks. Well, I think one of the main things that we need to, the research has shown that when you, task shifting can work, but we can't load too much. What is the tipping point that you can give to a lower level cadre with less skills, or a community health volunteer, for example? It's like, let's give everything to the community health volunteer, but there's a limit to what they can do as volunteers and in the extent of the services they're expected to provide. But I think the task shifting the loading dose of magnesium sulfate to the lower levels, not too low because then that's not tenable, but to primary healthcare facilities where they're trained to give magnesium sulfate and antihypertensives, not forgetting that. It's all very well controlling convulsion, but if the woman's blood pressure is not controlled, then she may well end up with a stroke. So use that to task shifting to primary healthcare, but also using opportunities for every contact with a provider and or a community health volunteer. I mean, some studies have looked at community health volunteers doing blood pressure at household level so that women know what their blood pressure is before they get pregnant. But also looking at every contact, whether the woman's coming for immunization for their child, for family planning, do they get their blood pressure done? Can we make sure that for every contact a woman has, whether it's herself or her family member, to at least, the very least, get her blood pressure done, and some information around healthy lifestyles.
Great. Thank you. Tabassum, you've done a lot of work in South Asia and other contexts. Can you also talk about addressing some of the systems failures?
So I think in low-income countries, in terms of turning the failures into successes, I think having women and their communities engaged has definitely been a success. And like Charlotte alluded to, women's groups where it's just not women, but elders, mother-in-laws, and other family members learn about the danger signs of pregnancy so that they are more aware. And there's actually culturally specific or adapted posters that a lot of women would have, for example, in Bangladesh, where they are looking at it every day and just making sure that they're aware of the symptoms. And similarly, engaging the male partners, religious leaders. So really community engagement. Along with that, the other thing that has been successful as part of my research, I'd been involved in the community level interventions for preeclampsia trial, or the CLIP trial, where birth preparedness and that financial preparedness also really came into play. So women had a transport plan. They had plans with their neighbors set up with finances and how they would manage that. And then taking that idea to high income settings, unfortunately, I think there are actually a lot more gaps in high income settings. May not be the same things, but when we're trying to deliver care, one of the areas where we're not doing as well is the cultural contextualization, or even again taking women's barriers into care. So with the survey we did with South Asian women in Vancouver, for example, they said that they'd like to have a South Asian health professional available, translators easily available, which aren't actually easily available, and childcare available. And then where we deliver care, and that goes to both low resource and health and high resource settings. Like you talked about, when women stay indoors for 40 days, that can actually be true in high income settings too, and our health systems has to be adaptive to that, whether we provide home visits or do phone or like telehealth. There's got to be other ways of delivering care so we can maybe start changing those failures and gaps into smoother care.
Great, thanks. So in most cultures, pregnancy is a time of celebration and joy and a very happy, hopeful time. But all too often, we know that these experiences can be traumatic, that they can lead to depression, anxiety, or post-traumatic stress disorder. And there's WHO data that shows us that depression is still the leading cause of disability worldwide. So, panelists, are we doing enough to address these psychological consequences of hypertensive disorders in pregnancy? What about the mental health of mothers? Are we thinking about that enough? So, Lucia, in high resource settings, what are you seeing in your practice?
Definitely not thinking about it enough. I would say, so certainly women with obesity and with gestational diabetes are at increased risk for postpartum depression, so we know that. And I work in a setting where actually I have a group of psychiatrists and therapists who specialize in taking care of peripartum women. And so I feel like we actually have a lot of resources, but I sometimes have a very hard time getting women who I've identified who need to hook up with them actually get to them. Some of it's because of insurance barriers, and they need to see someone else, or they have high copays, high deductibles, so they're not getting in. Some of it is because I think women think that if they're depressed, that means they're not happy they had a baby, and it's hard to sort of encourage them to see past that this isn't about how wonderful this event in your life is and how much you love this child, that you have a disorder just like women with hypertension have a disorder. And there's a lot of stigma. Sometimes it's family members and friends who actually have a hard time supporting a woman seeking help, and so that gets in the way. I do think that as maybe more celebrities come forward and talk about their experiences, then maybe this will become more socially acceptable. But it's definitely, even in a setting where it's as easy as it could be, every woman gets a postpartum screening done on them when they come to our office visits. So it's addressed at every visit, and we have people we can easily send them to. It's really hard to get them hooked up.
Charlotte, what have you learned about this from your work on respectful maternity care?
That women don't get any.
We should be laughing.
We conducted a study in Kenya on disrespect and abuse through the Traction Project, and we found that 20% of women felt humiliated at some point during their pregnancy and childbirth experience. So those women are unlikely to come back and seek care if they have any problem later on. And so in the postnatal period, as we've heard, it's such a limited contact with the health system. Once you've got a healthy baby, why are you even complaining? And we have seen that that when you have trust in the system, then you're more likely to seek care. And there was a study done in Australia that showed that factors that help women's experience were feeling safe, trusting the healthcare provider, and the continuity care, as well as the social support. So the problem is that the focus continues to be on the physical aspects, but we need to really look at the emotional and social support, which are important mediating factors for women. But I think this is definitely an area where we need to gain more insight in the long term, especially the long-term postnatal period, and looking at that and how HDBs and NCDs link. I read something recently that some women who have a hypertensive disorder in pregnancy may suffer from post-traumatic stress disorder up to 7 years or more after the birth itself. And we all know that what everybody says, you do not forget having your child. And if it's traumatic, then it's going to have repercussions later on.
Lucia, did you have a follow-up?
Yeah, I did just want to say that in the postpartum shared medical visits that we do, I do think actually one of the things that has been successful is that some women in those groups will actually very freely talk about their experience of depression during pregnancy or after pregnancy, and that often opens up the discussion for other women in the group who will come up to me later and say, oh, can I have a referral? I think it's time that I had an appointment. So I do think that's very helpful. The other thing is that I know this is about the women, but there are sometimes husbands are also traumatized by wives getting very ill, and sometimes actually they need help. And I think taking care of the whole family is one of the things that can be very helpful.
That's a great point. So Tabassum, you've worked both in high resource settings and low resource settings. What do you see that's different in mental health care across those?
So in high-income countries, I actually want to go back to what Charlotte said about PTSD, because pretty consistently in Vancouver and in Rhode Island where I've worked, there's been good support systems. Both have had a behavioral health or reproductive health mental team easily available, but women actually endorse these PTSD-like symptoms, and it becomes challenging when you want to order follow-up investigations. For example, the MRI machine actually comes up as one where they just don't want to go in there because it reminds them of what has happened and being rushed in there and not being able to organize that follow-up. The other thing that I've seen around the PTSD-like symptoms is apprehension around the next pregnancy. While they would like to get pregnant, they are incredibly scared. And through good support and, again, this group visit and being able to work through certain cognitive exercises, women I've seen have been able to successfully overcome that. In low-income countries, I wanted to mention that while these challenges exist, I think there is an additional component where it has to also do with if they've experienced something like a near miss, which can be very feasible in the context of preeclampsia, that we have to look at the interplay of psychological wellness and recovery, but along with physical trauma as well as sexual dysfunction, which can then lead to economic impacts, and then all the stigmatization with family, community, and how all that interplays. I'm not saying that doesn't happen in high-income countries, but I think it's a lot more pronounced in low-income countries, and we do need to keep that in mind.
Thanks. There's also the provider's experience. Providers aren't, clients aren't the only ones that experience trauma in difficult births. Can you talk about the provider's experience, Kathleen?
Sure, and this is another area where I think it would be really good to have more understanding and informative research. I think that, as we have increasingly acknowledged, the high prevalence of disrespect and abuse, in all income settings, Washington, D.C., Nigeria, throughout the world, that there is, as we think more deeply and systematically about this issue, we know that taking care of carers is not the only piece, but is part of really addressing this. And I think that in low-resource settings, particularly very high mortality, morbidity settings, where maternal mortality rates are like in the 600, 700 per 100,000, and I have worked in these settings, the cumulative effect on providers of day after day after day, witnessing these, traumas is just, I think, devastating. And obviously it's most devastating for the woman and her family, but I think we need to, if we want to address the experience of women and mental health needs, we need to address the mental health needs of providers. And I think Charlotte's work in Kenya, as well as other studies focused on trying to address disrespect and abuse and improve client-centered, meaningful care, have usually and often included components, not exclusively, but included components that are focused on supporting providers. I thought I would just say a word about also in terms of, between the high resource and low resource settings. I'm also very fortunate, and Mark knows this, in our consortium of community health centers, we have behavioral health, we have therapists, we have psychiatrists, and we, I'm sure like many of us, routinely screen not just postpartum included, but every single client that comes in. We use a validated depression screening tool, and I just think it would be really interesting to look at the use of a validated, you can just ask 2 questions and have a pretty good, strong idea, and, testing that a bit more in low resource settings and incorporating it potentially as part of Group A and C and ongoing Group P and C. I suspect there's probably been studies that have already been done on this, but I think it would be very interesting.
So we've talked a lot up here, and we really invite your questions and your comments to this great discussion. So let's open it up. Do we have any questions? Please.
I'm Indira Narayanan, an independent consultant in maternal newborn health and adjunct professor in Georgetown University. This panel was really fantastic. What you announced at the beginning really is true. I'm so glad that you covered from the community angle the importance of social behavior and communication strategies. And I was wondering if any of you had experience in using mHealth in this, because there are certain ways that you could find out something from mothers and also send us reminders to come back. I would also like to add that when referring these mothers, this is not a problem, as you've already highlighted, it's not a problem only for the mother, but also for the baby. So when you're going to refer these mothers, if feasible, it's better to have referral to a place that can handle the preterm baby as well. Mm-hmm. Because transferring a preterm baby, especially with eclampsia, you're more likely to have asphyxiated or intrapartum adverse events. So transferring such a baby is almost impossible. Thank you.
Okay. Great. Does anybody want to respond to that? Do we have? Mm-hmm.
Indira, thank you very much for making that really important point, and couldn't agree more. Under MCSP, we have a very integrated maternal neonatal approach, and our work on preeclampsia is very much focused as well on the needs of the fetus and making sure that we're thinking about where that mother-baby dyad needs to get care. And we know that preeclampsia and eclampsia is a leading cause of premature birth. So I thank you for bringing up that point. I think it's hugely important, and it's something that we work on a lot in our MCSP country programs, working with country counterparts. Thank you.
I wanted to comment on your question about mHealth. So I alluded to the CLIP trial, and there the mHealth component was a critical component. Unfortunately, it didn't have to do with reminders, but it was actually used by the community-level healthcare workers. So this trial happened in 2 South Asian countries and 1 African country. And the mHealth component was actually a risk stratification tool that gave the community-level health worker an idea of when to administer the medications, antihypertensives may exalt, and when to actually refer. And it was using a tool called Peers on the Move. So it was a critical component. And then using that, we had a small project through Grand Challenges Canada where we used an mHealth platform to look at the geographical and the social determinants of health and how that impacts a woman's risk, and again, allowing the community health worker to develop strategies. So this had more to do with infrastructure, like what's the season like? What are the roads like? How far away is she? So building on that model. And just a quick example from high-income countries, I've never used it, but I just learned about it. UPenn actually developed a platform to screen women for postpartum hypertension. So women would measure their own blood pressures, they would put it into the tool, and it would feed directly into the EMR. So then the providers would get these updates and be able to bring women back, the ones who needed to be. But that's UPenn. We have not done that yet in the settings I've worked.
Interesting. Another? Let's go with you.
So I'm Rita from MCSP Javigon. Thank you so much. Clearly, the conversation today really gave me goosepimples. I worked in the public sectors of India as an OBGYN for 35 years. And, Kathleen, what you spoke about the provider, the problems that the provider faces. I know at a primary or a secondary level hospital, a provider would see up to 200 ANC clients a day, not giving not more than 1 to 2 minutes per client. So clearly we have a lot to do. And after listening to you, I actually went back to that little ANC area, which I've also seen in Kogi and Ebony in Nigeria. There's a small room packed with women, jam-packed with women. And, where is the space to talk about these things? So clearly, there is a lot to do, and especially health system strengthening. All our learnings have to go there. So my question to Charlotte is, how can we better, what are the plans to better merge the NCD into the existing maternal health agenda? I know we have miles to go before we sleep.
Thank you for that very challenging question.
Well, and everybody could respond to it as well.
Yeah. No, I think that we need to provide more support to those primary healthcare facilities who are seeing these women extensively. One thing that we've done under the Endingeclampsia Project is to try and use different cadres to provide health information while those 200 women are waiting to be seen, so that they're not just sitting waiting, they're receiving some kind of information that is interactive, not just another boring health talk that most women will turn up late so they miss it, or the providers won't start the day of seeing anybody until everybody's come. So I think it's looking at again the task shifting of key components that the skilled provider doesn't have to do, that other people can do, and working as a team to provide those services to those women. There's a lot that can be done there. So regarding the NCD piece, again, every contact to try and have somebody do the blood pressure, or have blood pressure machines that the mothers can use themselves and take each other's. This kind of group antenatal and postnatal, I've been to facilities where mothers weigh each other's babies. So let's extend that to blood pressure and testing urine. So I think we can, if we look at it as a team approach, both community and whoever's available as a provider, to help the health of the community.
But how is this going to happen? The ministries of health or the health systems have to be strengthened so that it goes down to that level, and there is an awareness about the importance of NCDs. 11 women dying in a minute, is really too much.
Can I say
I
something,
don't know
Jill?
how our learnings are going to reach that point. Catherine?
Well, I think building on what Charlotte said, which I completely agree with, and I'm sure none of us have a perfect answer to this, and we just have to commit and move forward. But I think, from my perspective, having much more multidisciplinary, approaches. I think that I'm a family physician, so I've done OB rotations, I've worked with internists, I've worked with neonatologists, and I'm amazed how, at least in global health, and I think to some extent in the US, but it's changing, how cutter-driven we are. You're a midwife, or you're an OB, or you're a family physician, or you're an internist. And I think that, if we really want to move this agenda, we have got to start really talking to each other and working, looking at women across the entire life cycle and recognizing each other's very important, expertise, but really building a broader vision together and, helping to support that vision at the global level in terms of advocacy, at country level, et cetera. So that's just my perspective. But I also agree with everything Charlotte said.
Anybody else?
I was going to say, to merge the NCD and maternal health agendas, I think you mentioned it yourself, it's the awareness. Speaking at a high level, if you ever go to these NCD talks, when they talk about women's health, it's diabetes, cervical cancer, and breast cancer. There is no mention of any of the pregnancy-related things we talked about, gestational diabetes, preeclampsia, none of those stresses at all. So I think that would be my first suggestion, is that we need to raise awareness. Like, Women Deliver is doing a lot, which is great, but nothing related to pregnancy-related medical complications.
Yeah, good point.
We've got a question there.
Hi, I'm Bernie Gonick, USAID. This is for anyone on the panel. Is there any work being done from a prophylactic standpoint, in other words, low-dose aspirin for these patients, either globally or at risk in developing countries?
Well, currently, based on a meta-analysis, we are giving 81 milligrams of aspirin to women in the U.S. who have risk factors for preeclampsia, hypertension, or previous early preeclampsia. I'm not sure if that is different in other settings, though.
Yeah, we're starting to do this in MCSP programs, and it was helpful to have the WHO recommendations come out, and the preeclampsia as well as the ANC, and we are starting to do this, particularly when women come early enough in pregnancy and enroll in ANC. I think the challenge we often face is that women are coming late in the third trimester, but we are routinely screening for risk factors, either past episodes of preeclampsia or other risk factors, and administering low-dose aspirin in a few country programs. And then also calcium in countries where women live in populations with low calcium intake. This is not tailored to the individual level like aspirin, but where there's low calcium intake, we are also beginning to promote calcium supplementation. I don't know if others want to add.
We have a question there.
Yeah. Thanks. I'm Mark Hathaway, also an OBGYN with MCSP Japigo, and there was many questions I could ask and thoughts I have, but the one I think that really struck me was, I'm thrilled to hear you talk about preconception. We have this notion that, a bell goes off when someone becomes pregnant, a woman becomes pregnant, and then we jump and we start doing things. But I think, as you pointed out, or several of you pointed out, there's so much that needs to be done. So my specific question is, what are some things that you would include for low resource settings to look at for a woman who's thinking about becoming pregnant? You mentioned BMI. Is there a level you would say you should try to get your BMI to X? Or is there, folic acid is not so readily available, but all kinds of things. Are there packages that we should be thinking about in low resource settings towards preconception care?
So, I mean, the basic thing is that healthy women tend to have healthy babies. So whatever kind of medical disorder, whether it is an elevated BMI or diabetes, hypertension, controlling all of those things going into pregnancy is important. Making sure that women are on medications that are not teratogenic or on appropriate medications for pregnancy, and that they continue to take medications that they need to take even during the pregnancy, like, for instance, asthma medications. That's very important. So it's sort of that preparation for that. And then having the discussion about weight loss. You know, we know from DPP that even just decreasing your body weight by 7% can decrease your future risk for cardiovascular disease and diabetes in the future. And so, you know, many women, that's not a whole lot of weight. You know, it's not 50, 60 pounds for many women. It is more in the range of, 15, 20 pounds. So that's more doable. But that's not always an easy thing to do. And really important to make sure that women are screened for diabetes so that we know about diabetes in advance of becoming pregnant. Physical activity, too. Yeah.
Okay, another question?
Thank you. My name is Cecilia Van Hollen, and I'm a research fellow here at the Wilson Center. And speaking of interdisciplinarity, I'm a medical anthropologist. I was interested to, a number of you spoke about the importance of, getting women's perspectives on obstacles to detection and to care. I didn't hear much about obstacles to prevention. Which speaks to the issue in this particular instance, particularly of nutrition and exercise and so forth. And while there are, of course, unique cultural issues to obstacles in all of these arenas, at the end of the day, there are some sort of basic commonalities that we can see across all of these contexts, right? That are about time and money, so I guess my question is, you spoke about the importance of gathering more information from women themselves about their, about the specific obstacles, and these are, in many cases, they're going to be, I would think, class, gender, race, ethnicity, caste issues in India, where I also have been doing my research. So my question is, what do or can you do with that kind of information to work perhaps not only with ministries of health, but with other, community-based organizations, but also with other areas of government and sort of pushing for certain kinds of legislation to address these sort of broader structural issues. And I know that's, that's you can't take on everything, but I am curious to know, how much you interface with agencies beyond the public and global health agencies specifically to address these broader health issues.
Thanks very much for the question. I think it's a really important one, and the importance of multi-sectoral work, I think, is just critical. I mean, we know in the U.S. that, it's population health issues that really have given us some of our greatest benefits. And I don't think we do enough of it. I think, we tend to be quite siloed. And I think this also is the way many ministries are structured as well. You have, even within the Ministry of Health, you have NCDs, you have nutrition, sometimes completely outside of the Ministry of Health. So I think it can be greatly challenging, but I really take your point on the importance of it. And I have been involved with some programs that have really tried to tackle this. I think things like anemia are places where we've maybe done better because we've had to work across nutrition, infectious disease, public health. The first thing that came to my mind as I heard you speaking is I think in high resource settings now around quality, we're more and more finally looking at disparities and inequities in access to care and the most vulnerable. And I think that the lack of access in terms of, as you're saying, to healthy food, the structural barriers is, inordinately carried by the most vulnerable. And I hope that we will start, and I know that USAID is doing this in many donors, but I hope we'll start having much more focus on disparities and really trying to measure them and understand them as part of our quality and broader, public health and, and beyond work in the next years. So no easy answer, except that I think we should all commit to it and maybe look for good examples. I have not seen a lot of really great examples personally. I don't know if others want to have you,
No,
Charlotte.
I was just going to add that we must, work with adolescents and young adolescents to, if we're trying to prevent obesity or any of these things prior to getting pregnant or delaying that first pregnancy. So I think doing work with adolescents in schools about healthy nutrition and lifestyles at least can begin to look at the prevention. And there's lots of other things we can work with adolescents, but also listening to them and what their needs and their aspirations are, I think is key to changing the way that we're currently working.
I think we have one last question.
Well, oddly, my name is Laurie Krieger from the Manoff Group, which, if you don't know about us, works in social and behavior change. And one of the things that, it's very odd that I'm also a medical anthropologist, although we didn't know each other. Some things struck me. I mean, first of all, I realized how incredibly ignorant I've been about preeclampsia. But also, I wanted to just highlight rather than ask some of the structural and other issues that you've raised that I think are extremely important, and I don't want them to fall, as less important points because they're so important. And one of them is when you talked about, for example, in some Muslim countries, not all, and in Ghana and some places in Ghana, there's certainly a postpartum period in a lot of the developing world where women can't go outside. It's either because the baby's not fully human yet or that we're social or for whatever reason. That I really wish you would see not as a barrier but as an asset. Because the woman, it was mentioned that in developing world, developed countries, industrial countries, women tend to have less support. They have more things, lots more things to do postpartum. But in these countries that have this practice, it's not the same. It's the exact opposite. Women have more support. Other women will cook for them. And I think, I can't remember whether it's Kathleen, someone mentioned maybe we need to look at how we deliver healthcare and not have a fixed site. And that is incredibly important, that we be flexible. And then also, I think we need to look at context very broadly and not see barriers, but rather see what is going on. I mean, this is the difference between a lot of people in public health and when I do research, I don't go in and say, well, this is the ideal of what people should be doing, and then this is behavior. Oh, I shouldn't say it, that's what my organization does. And then, so what are people doing and why aren't they doing, what we think they should do and how close can we get them to? And I go in and saying, what's going on here? And how can I understand the complexity of what's going on here? And then how does it affect health and what we think people should be doing? And I'd just like to pose that. If we do that, then we look at insurance as basically in the United States, it's basically a subset of the fact that we have a privatized healthcare system. And that there are standards, there are protocols, but there's not really healthcare for all. So that's basically what I wanted to say, and thank you so much because I've learned so much, and I think you've highlighted everything that's important. Thank you.
Great, thank you. I'm going to ask a last question to the panel, one of my favorite questions. you all have just become donors. You've got $1 million. You have to make strategic decisions. It's not a huge amount, but it could be a catalytic investment. What would you invest in? Let's start with you, Lucia.
I actually will have to decide between several things, because it takes a lot more than $1 million. But I think that in a high resource setting, we have a lot of providers who actually need better information around preeclampsia, the risks for preeclampsia, modifying those risks, and also into the postpartum period and preventing future health issues. So I guess I would like to spend some money on helping our medical system not be so siloed and to have more interdisciplinary work. I guess I would also, and that probably gets into the insurance system and having ways to help providers actually be able to easily provide this kind of care to patients in a sustainable way, because unless you have special grants, sometimes it's very difficult to actually set up a system to actually deliver care that's helpful. I guess I'll say that.
So I would like to use the money to invest in dedicated postpartum clinics to prevent cardiovascular risk. It's something that I've wanted to do in the US, but due to insurance barriers can't. So Canada already has started this in pretty much all provinces where women who have been identified following preeclampsia, it's anybody, and it's not just preeclampsia. Some people actually screen women with increased body weight, some with some of those placental syndromes I talked about, like infarction and abruption. So I would put the money into a clinic where they would see a multidisciplinary team that includes a nutritionist, an exercise physiologist, and maybe even have group exercise and then follow them along and then ultimately send them to either a primary care physician or if they need another specialist. But I'd love to invest the money in these dedicated clinics.
Great. Kathleen?
Thank you. I'm actually looking at many of my colleagues and thinking I'd love to hear their answer to this question. I think I would be divided between two things. One would be to work at a very specific country level, even at a subnational level, co-designing, working with local counterparts, subnational Ministry of Health, other partners, to really look at how we can build on assets that already exist within systems and platforms to better tackle the continuums of care across system levels as well as life cycle, and really kind of dig in and get the hands on the noodles, as we say, because I think ultimately this has to be co-designed and it has to be sort of led locally. My other is very different. My other would be to look at some of the global platforms like the Quality, Equity, Dignity framework and network that has a lot of buy-in, a lot of donors, a lot of WHO, UN agencies, and country, and like really use that to try and push the agenda to look at women's needs and risks, across a much more extended period using, platforms that are already being really bought into.
Charlotte?
Thanks. I was asked this same question about 20 years ago, and my response was invest in tarmac, build roads. But basically that means strengthening the referral system so that women get care in the right place at the right time. And I think that piece of connecting the community or where the women are to the right care is critical to save lives.
Great. Well, thank you. This has been such a really great discussion today. I think we've covered a huge range of issues, and it's really difficult to sum it up. But one of the things that I was struck by is the similarities in the issues across high resource and low resource settings, and the similarities of approaches and models that can be successful. So I think that each type of setting can learn from each other. One of the things that's really clear to me is that health systems need to be reoriented to effectively manage these diseases and to be made more person-centered, and not just person-centered during pregnancy, but across the entire continuum of care that we've talked about. It was mentioned that women's contact during pregnancy, especially in low-resource settings, provides a great opportunity to address NCDs. But we really need to think about what that looks like, how you provide that integration. Is it a multidisciplinary clinic like Tabassum talked about, or is it being able to link these services through really effective referral networks? And then there's the question of financing that has come up. And I think it's really interesting. Often in low-resource settings, we talk about financing for services in a very different way than we've talked about financing and payments within high-resource settings. But I think that the financial barriers and how we organize how services are paid for is critically important across all of this. And this really links in with the universal health coverage agenda, which we've been hearing a lot about at WHA this week. And ensuring, I think is really important as we're all talking about UHC, is ensuring that NCDs are, and NCDs within pregnancy are part of those UHC discussions and that agenda to move a country towards broader coverage. They can't be left out of entitlements or benefits packages, all the things that governments need to offer their women. So there are a lot of challenges that are ahead of us, but I think that we have really addressed some new ideas and some learnings, and hopefully we're all coming out of this with a little bit clearer idea about how we begin to tackle these issues in global health and in high-resource settings. And this is the second World Preeclampsia Day. I really look forward to seeing everybody on the third World Preeclampsia Day, where we can talk about how we've applied these lessons and what our successes are over the next year. So thank you everyone for turning out, and we'll see you next year.